Good evening, everyone, and welcome to tonight's webinar called The Challenges of the Cornea with Dr. Justin Schweitzer. This is a Wu University webinar, and I am your host, Dr. Elise Kramer. Thank you so much, Dr. Schweitzer, for being with us tonight. I'm super excited. So a little bit about Dr. Schweitzer. Dr. Schweitzer, OD, was born and raised in Jamestown, North Dakota, and he attended Jamestown College and graduated with degrees in biology and business administration in 2002. And then he attended Pacific University College of Optometry, where he graduated summa cum laude in 2006. And in July of 2013, he completed his fellowship training in advanced anterior segment surgery care and pathology at Vance Thompson Vision. He's a member of the American Optometric Association, American Academy of Optometry, Scleral Lens Education Society, and the South Dakota Optometric Association, and he has published multiple articles in scientific journals. Thank you so much again for being with us tonight.
Thanks so much, Elise. Excited to be here. Looking forward to the next 50 minutes with everyone. And just a real honor to be invited back to Wu University and to be able to spend this time talking about some things around the cornea. Appreciate everyone taking time away from their family, friends, significant others. I know that's never easy after a long day in clinic, in the trenches, seeing patients and taking care of patients. So that is not lost upon me. So I really do appreciate so many of you taking that time to join me. Tonight, I'm really going to try to focus on 4 cases. We have limited time, about 50 minutes. So to get through 4 cases may be a little bit challenging, but I'm going to do my best. And I think what you're going to find out as we kind of get through these various cases that, some of it's going to be a reinforcement for a lot of you, meaning you manage a lot of these patients on a daily basis. It's going to reinforce some of the things you already know. For some of you, it's going to be new, which I think is great. And for some of you, you're going to say, boy, I don't know if I would have done it that way. And I don't have a monopoly on the truth. I'll try to back up my answers and my thoughts with published literature and what's out there that we've learned through years and years of caring for patients. But that's the beauty of what we do on a daily basis. We practice eye care, we practice optometry. And so as I go through these cases, I hope you enjoy the 4 that I've kind of picked out to go through with all of you. And all these cases are ones that, I've managed in my clinic alongside, sometimes it's a resident, sometimes it's our fellow, other times it was just by myself. So again, just appreciate everyone's time, and we'll jump right into this so we can stay on time and try to get through all 4 of them. So this was a 44-year-old patient that presented to me, and this was referred in by a colleague in the community that had been managing the patient, and the patient had some blurry vision, photophobia, unspecified corneal edema in the left eye, and been treated 2 months ago with these big pills, is what she told me in quotations. Vision 2015 in the right eye, but you can see in the left eye 2600 vision. So we never like to see that. Her intraocular pressure was fine at 12 and 14, and then did do a pachymetry mainly based on what I had seen on slit lamp. And you can see a big difference in the patient's corneal thickness, especially their central corneal thickness, 542 in the right eye, 684 in the left eye. When you look at the image on your guys' left there, I kind of tried to highlight an area. We don't have, a slit lamp in front of us here. We aren't able to see 3D, so there's no stereo here. But as you can tell, there was this kind of round area, and it was perfectly round, of about 2+ corneal edema. There appeared to be some guttata in that specific area as well, some injection, and then a small amount of cell in the anterior chamber. And then the other image on your right, again, very difficult to tell, but if you look very closely, there were small keratitic precipitates that were coating the corneal endothelium. So those 2 particular images there. So that's kind of the background of the patient. You have that. And so I've thrown a lot of different polling questions in here. And so we're going to throw one at you right away. With what you have in front of you there, what would be your diagnosis? And I'll make it multiple choice. Would this be an HSV disciform keratitis, HSV keratitis, infectious keratitis, or more of an infiltrative keratitis based on the clinical picture? And we can go ahead and pop up the results. Yeah, so 40% of the group saying an HSV disciform keratitis, and about 36% saying an infiltrative keratitis. And so the group is right. The high percentage, this was an HSV disciform keratitis, really for a variety of different reasons. I'll back up. A couple of things that jump out right away. The patient's history with a lot of different corneal conditions kind of gives you an idea of what you may be dealing with. These big pills, when we think about big pills and something that patients take a bunch of, a lot of times I think of our antiviral types of agents. The other thing that jumps out at me here when we think about anything from a herpetic standpoint is this round corneal edema. If you see excessive corneal edema, it can be infectious, but a lot of times herpetic conditions need to be at the top of your mind. Excessive corneal edema. This disciform appearance, this perfectly round area, another thing that was very obvious and something that is a red flag for something herpetic in nature. The KPs, the inflammation in the eye with the anterior chambers. Again, all things that should make us immediately think this is very likely something herpetic in nature. And then were the guttata true or not? We'll talk about that here in a little bit. But those are kind of the reasons behind why I was thinking, as the group said, that this was very likely a disciform HSV keratitis. So how are you going to treat this? Poll number 2, you've made the diagnosis. How are you going to treat it? Got 4 different options there. We'll launch that poll again. We have our oral antiviral. We have an oral antiviral plus a topical corticosteroid. We have a topical corticosteroid, or we have our oral antiviral plus topical antiviral. Give a minute here. The poll should launch shortly here. And with all these poll questions, I'm trying not to be overly tricky. I know there can at times be multiple answers, but I think for this particular case, there's probably a more correct answer for this patient for a variety of reasons. And the reason why this patient didn't get better is part of the reason why the answer to this is so important, because this particular patient was put on oral antivirals. This patient was treated with an oral antiviral. The doctor made the correct diagnoses, but the problem was there needed to be additional treatment along with that. And this group, you nailed it, 61% saying that oral antiviral, which is necessary, but we really have to add a topical corticosteroid. We're not dealing with an epithelial HSV here. We're dealing with something that is in the stromal, really dealing with an endothelialitis, a disciform keratitis. That's why you're seeing some of those guttata. That's why you have the corneal edema, but there's no epithelial involvement. And so that topical corticosteroid is very important in this particular case. So when we think about HSV keratitis or HSV in general, not specifically just keratitis, remember a lot of the times it's unilateral in presentation. Of course, it always presents like that image that you're seeing on your screen right now, right? If it presented that way all the time, we'd make the diagnosis accurately 100% of the time. In 10 years that I've been at Vance Thompson Vision, I could think of maybe one time, and that's the patient that I've had an HSV keratitis or dendritic keratitis that's looked like that. Otherwise, it's always a little more tricky. But if we see that unilateral presentation, we see an iritis with a high IOP, we have to at least think of herpetic or some type of herpetic etiology. Remember too with HSV that quite often these patients, especially stromal, especially endothelialitis, will reoccur. 70 to 80% of the time we can get a reoccurrence within roughly 10 years. So when we think of the different types of keratitis out there or HSV or herpetic conditions, we have epithelial in nature, the dendritic forms, the geographic ulcers, the marginal epithelial ulcers, and we'll talk about treatment here for that in a second because we treat that differently than the way we treat something that's stromal in nature where maybe the epithelium isn't involved. Now, keep in mind, a lot of times the epithelium and the stroma can be involved, and I'll touch on treatment with that as well. We have our endothelialitis, our disciform keratitis. We just talked about a patient just like this, where you can have pseudoguttata, not true guttata that's coming from the edema that's coming from that disciform keratitis. And then really what we're trying to avoid, the neurotrophic component. And I'll get into that a little bit here as well. Probably the most common reason that I see neurotrophic keratitis in our practice comes from herpetic types of conditions of the cornea. So how do we manage these 4 different scenarios? How do we manage the epithelial condition, the stromal, the endothelialitis? Well, typically we always need to consider having an oral agent on board. And I've listed your oral options there for you. On the left there, we have our acyclovir, our valcyclovir, our famciclovir, and our dosages when we're dealing with a herpetic condition, whether it's epithelial, whether it's stromal, whether it's an endothelialitis. Now, one thing to keep in mind when we're dealing with something that's epithelial in nature, so we'll start with epithelium first. We don't want to put a topical corticosteroid on the eye. We want to start with something like on the left there, an oral agent. And you can begin with just an oral agent and be just fine with that. We know that the oral agents reach therapeutic levels in the tear film. So you're just fine in an epithelial HSV keratitis to go ahead and just use those oral agents. Now, if you like to use topical, I have no problem with that. I'll tell you the majority of the time that I manage the HSV epithelial keratitis, I just do orals. Now, you can add one of the agents on the right. If I had to pick or lean towards one, it probably would be ganciclovir, the ophthalmic gel 0.15%, mainly because trifluoridine very hard on the corneal surface, and really even ganciclovir, if you're on it for an extended period of time, can be pretty hard on the ocular surface as well. And that's why I'm a fan in epithelial HSV keratitis, just really lean towards doing something oral, unless the patient isn't responding to the oral as well as we would like, and then you could add that topical agent as well. When we're talking about a stromal condition, stromal by itself, or endothelialitis by itself, then what I would consider doing, or what you should do, is you need to do the oral agent, the oral antiviral, the ones on the left, but then you need to do a therapeutic dose of topical corticosteroid. And I would dose that 4 times a day because there's no epithelial involvement. And if you don't do that, trust me, the stromal and the endothelialitis will hang around. It won't completely resolve. It will wax and wane, and it will create challenges for you clinically. That clinical picture is more difficult. And so very important to add that topical therapeutic level of a corticosteroid to manage these patients, along with covering with that oral antiviral. And you never want to stop the oral antiviral until you know you're going to stop the steroid in these cases as well. If you have a combination of epithelial along with stromal, treat the epithelium first. Yes, they're going to have some edema. Yes, their vision's going to be not good. And you're going to be concerned about what's going on with the stroma, but you want to get the epithelium healed first. And so put them on that oral antiviral, hold on that topical corticosteroid. Once the epithelium is under control and looks healed or reepithelialized, then that's when you want to think about adding your topical corticosteroid, which often enough, that is how these present. Not always do they present beautifully with just one or the other. A lot of times they combine as well. Prophylactically, there are times when you need to do this. For me, when I think of prophylaxis, it's not after the first time they have one of these types of keratitises. The second time I may consider it, I really base it on the level of scarring that the patient has, or the level of the disease process. Was it really significant? Was it very mild? If they get it a third time, 100% of the time, I'm going to put them on a prophylactic dose. And this would be your prophylactic dosages, and you do that out to 1 year. Why prophylactic therapy? These would be 5 different reasons where you'd want to consider prophylactic therapy for your patients. List of these will be in your handouts as well, so I don't need to spend a lot of time on these. But there is a variety of reasons why you'd want to at least consider prophylaxis. And then just in closing with treatment principles, I mentioned you always want to treat the epithelial disease before the stromal, if there's a combination of the two. Remember, anytime you're treating either the stroma or you're treating an endothelialitis, you got to make sure that if you're using the steroid, you want it to be therapeutic, but you also need to have on board the oral agents as well to prevent any reoccurrence. And then keep in mind, a lot of times with stromal or endothelialitis, these patients may never completely get off a topical corticosteroid or even a prophylactic oral agent. I have probably a half a dozen patients in my practice right now that will, for the rest of their lives, be on a drop of lodiprednol, and they will be taking a prophylactic dosage of an antiviral, because if I take them off it, it flares back up on those particular patients. And so keep that in mind as well. Nice question came up in the chat. Are there any mimics of HSV disciform keratitis? Probably the most common would be acanthamoeba. It's interesting. I've had a couple cases where I've treated an acanthamoeba patient thinking it was HSV keratitis. And I'm messing up your question because you said disciform, but I've had a keratitis where it looks like a dendritic keratitis and it was actually acanthamoeba. So you need to be aware of that. Other mimics of HSV disciform keratitis, patients that have chronic edema, you have to, that could mimic as well. I think the key take home in this case is just the the variety of red flags that you run into, KPs, a perfectly round section of edema, and anterior chamber reaction as well. Topical steroid overnight. Nope, I do not typically do it overnight. 4 times a day is all I really do. And that 4 times a day typically does the job in these particular cases. I don't really get overly aggressive with that. For a heavy patient, when do you go to 800 milligrams of acyclovir? Yeah, good question. So a lot of times I won't jump right to the higher dosage of acyclovir unless the patient isn't responding to it. So I stick with what I have there, 5 times a day, 400 milligrams of acyclovir. My personal favorite is using valcyclovir typically, but I will at times, if the patient isn't responding to that dosage, I'll go to the HZV dosage, which is really double of what you saw there. Couple other questions popping up here. A question about rose Bengal on keratitis epithelium. Yeah, rose Bengal is a nice stain to use if you're trying to determine, what's going on with those corneal epithelial cells. It can help in the diagnosis if you're not quite sure if it's HSV keratitis or not. I don't use it a lot, mainly because I look at the clinical picture, it burns, so patients don't love it. But I think in certain situations, when you're not quite sure what you're dealing with, that it's a good thing to put on there and look for staining around that lesion. And if it stains pretty heavily, your suspicion of an HSV keratitis has to go up. Finally, the last question here. Would I prescribe oral antivirals for less than 10 days or the full 10 days? I typically go the full 10 days. Keep in mind that oral antivirals are very, very safe. So safe medication. I'll go longer than 10 days. I've had patients on it 14, even out to a month at times. And again, you could go out to a year with some of these patients at times. That's the beauty of oral antivirals. They're overall very safe. Obviously, with a patient that has kidney or liver issues, you may want to be careful with it. But the majority of the time, our oral antivirals are very, very safe. So really some great questions that popped up. I'm going to continue to move on. And if there's some other ones that do pop up, I'll jump into those as well. So next case, we're shifting gears. I'm giving you guys hints already. Trying to get my chat box to close. There we go. So this was an 82-year-old Caucasian male that came in to see us. He was referred in because the referring doctor had been really trying to manage the ocular surface quite aggressively and doing pretty well at it too. It's just the patient wasn't responding. So the vision had been on the decline. He really wasn't sure why. His eye felt fine, but he didn't see well. You can see his vision 2250 in the right eye, 2050 in the left, and intraocular pressure at 17. Poorly controlled diabetic. He'd had multiple eye surgeries as well, also on a prostaglandin analog since 2000. So really a 20-year period where he'd been on a prostaglandin. Current treatment was a cyclosporin twice a day in both eyes, preservative-free artificial tears. And his fundus exam looked normal. And then this was the anterior segment exam. And this was in both eyes. He had really significant corneal staining, but no type of epithelial defect, just this diffuse SPK, punctate epithelial erosion across the cornea. So poll question number 3, let's go ahead and launch this. What other tests would you consider in a patient like this? And again, not trying to be tricky. I actually think all of these would be something you could consider, but is one maybe better than the other for a patient in this particular situation that's had multiple ocular surgeries, has had non-responsive SPK, punctate epithelial erosion of the cornea, that's been treated with a cyclosporin, that's been on a chronic glaucoma medication for an extended period of time. Yeah, so 71% of you nailing the answer here and what we should at least consider. I think mybography, yes, is an option. I think looking for inflammation is an option. And I think looking at the tear breakup time, definitely an option. I would argue you could do all 4 of these, but I think the most crucial one for this particular case, for this particular patient, would be checking this patient's corneal sensitivity. And that's really what I did. And when I tested this patient's corneal sensitivity, he really had 0 sensitivity, complete anesthesia. I used a cotton swab applicator to do this. And so this patient I diagnosed with stage 1 neurotrophic keratitis because of that central superficial punctate keratitis. And we'll go through a little bit on how we stage these. So the next question I have for all of you, knowing what this patient's been treated with, what would be your treatment option? And I threw some out there. And again, there may not be a wrong answer on here. Would you do A, an amniotic membrane or a bandage contact lens with punctal plugs? B, would you consider adding a topical corticosteroid along with the immunomodulator, which the patient is already on? Synendromin, which is a medication that is available now for neurotrophic keratitis, or would you figure out a way to get him off the prostaglandin? And again, it may be a combo of these. I know you can only answer one, and we'll kind of discuss and go through this. We can go ahead and launch the results. Yeah, so 42% of you saying, I'm going to try an amniotic membrane graft with a bandage contact lens and do some plugs. I have no problem with that, especially with a stage 1 NK patient. 23% coming in third. I see 29% saying we're going to go to synendromin, and we'll talk about that here in a little bit. Removal of the PGA is something that I would consider. What could we consider in doing that? Maybe just giving the patient a short break, a short drop holiday, depending on the level of the glaucoma. If it's a severe glaucoma patient, maybe less likely to do that. A very mild glaucoma patient, I would consider that. And then topical corticosteroid, I think that we know when we see corneal staining that there's inflammation there. My rule of thumb typically with a stage 1 neurotrophic keratitis is I am going to exhaust a few other options before I jump to synendromin. I like synendromin. I use it often. We're going to touch on it here in a little bit. But with stage 1, I like to exhaust other options. And then in some of your states, in order to get it covered as well with stage 1, you actually have to exhaust some other options, typically, whether that be using an immunomodulator, maybe plugging or an amniotic membrane graft. You have to fail with that first in certain areas and certain insurance carriers. Now, I have no problem going to it, but I do like the idea of exhausting maybe another option. Now, this doctor had already started an immunomodulator for an extended period of time. The severity of the NK on this patient as well really pushed me on what I was going to do for this patient. And I actually did go ahead and prescribe synendromin, which is dosed 6 times a day for 8 weeks. I could continue with preservative-free artificial tears. And I did stop the cyclosporin just because I didn't want to complicate or create compliance issues for this particular patient with having to take the synendromin 6 times a day for 8 weeks. And you can see the benefit that this patient got from that particular medication. He wasn't perfect at 8 weeks, but what a difference we made in his life, going from that 2250 vision to 2070 at 4 weeks to 2040 at 8 weeks, and allow him to be functional again. And then we're definitely going to have to continue to manage the ocular surface. How would I do that in this particular patient? I would definitely consider plugs. I will definitely consider adding back the immunomodulator to maintain this. I will definitely consider if there's any meibomian gland dysfunction managing that, and continue to do artificial tears as well. And so even though I went ahead and prescribed the synendromin, and that is what got him to where he is at 8 weeks, this patient is someone that we still are going to have to monitor, still follow, still manage and take care of the ocular surface. So with NK, there's a lot of etiologies. You know, you have the HSV, the HZV. I talked about that earlier. That's probably the most common reason that I see it, herpetic conditions in my practice. There can be nerve palsies as well, topical abuse of medications, or patients that have been on topical prostaglandins or topical medications for an extended period of time, multiple surgeries, maybe chemical burns. This patient had really all these different things, right? They had multiple surgeries, uncontrolled diabetes, had been on a topical medication for an extended period of time, had chronic ocular surface disease, which really led to his NK, and he needed some pretty aggressive therapy in order to get him to a good spot. And we classify it, why this patient was classified as stage 1, really being because he had punctate epithelial erosions. That's a stage 1 NK situation. Stage 2 would be a persistent epithelial defect. There's no stromal thinning, but it has this persistent epithelial defect. And stage 3 would be stromal involvement or a corneal ulcer or melting that's occurring. And of course, we're trying to avoid stage 2 and stage 3 as much as possible. When we look specifically at what synendromin is doing, and I know you're going to get more of this throughout this corneal series if you attend some of the other Wu universities, so I'll briefly go over this. Really, these endogenous nerve growth factors, which is what synendromin is you get cell proliferation, you get corneal reinnervation, and you can get tear secretion. We know that with NK or neurotrophic keratitis, we're losing corneal sensitivity. We lose corneal reinnervation. We lose corneal reinnervation. And you can get tear secretion. We know that with NK or neurotrophic keratitis, we're losing corneal reinnervation. We lose 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 corneal reinner And so we need to somehow get that sensitivity functioning better. And really what endogenous nerve growth factors do is it helps to maintain or build up the corneal integrity again to help our patients. Cenobamate is approved. So this is approved for patients that are age 2 and older. It's approved for NK or neurotrophic keratitis. It's been around since 2018. When we look at the big clinical trials on this particular study, these particular patients all had stage 2 or stage 3. So in these studies that you're looking at here, the Reparo study, which was done in Europe, there was a US study over there on the right, all stage 2 and 3 neurotrophic keratitis. You can see at 8 weeks, 72% of patients in the Reparo study were completely healed, 65% in the United States study, and even more impressive when you look at the Reparo study specifically, 80% of patients remained healed out to 1 year after having this dosage done. I still would recommend managing the ocular surface. This isn't something where we treat and then we ignore what's happening with the ocular surface going forward. So a couple quick questions just popped up. Yeah, really good question on my experience with insulin drops. I have used that in a couple situations. We've actually used it on 2 different patients in a situation where you're unable to get Cenobamate, and it was an option. There's literature out there around using topical insulin drops that need to be compounded in managing neurotrophic keratitis. And actually both those patients did quite well with it. So I love that question. Really, really good question. Difficulty with insurance payment for Cenobamate. Again, type 1, you may run into it at times. Type 2 and 3, almost no issues. We've, really not seen it with type 2 or 3 having any problems, or stage 2 or 3. Stage 1, you may run into some issues. You may need to exhaust other options before you prescribe it. But if it's a patient that you've done corneal sensitivity testing on, that's a key. You got to do corneal sensitivity testing and you have to document it in your chart. If you don't do that, then you'll have some difficulty getting it covered. But if you do document it and it is stage 2 or 3, no real issues. Stage 1, you may have to exhaust a few other options beforehand. Quick question. How do you go about the cotton tip test? So typically what I do is I take a forceps, I create a little tiny cotton wisp. So cotton applicator, create a little wisp. If it's the patient that has, let's say, for example, has had a herpetic infection just in one eye, which typically it is, the other eye is normal, and I believe that the sensitivity is bad in the herpetic eye, I'll test the normal eye first. Patient doesn't love that. They're like, yeah, I can feel that. Stop doing that. That's uncomfortable. And then I will go to the eye that doesn't have sensitivity and I'll ask them to compare it. And usually just by watching the reaction, you're able to tell. In this particular patient that you just saw, he had NK actually in both eyes because of the long use term of the prostaglandin analogs, the use of his multiple surgeries on the eye, and then also just having this chronic dry eye. And so I just tested, one eye, tested the other eye, didn't really choose which one I was testing between the two. And then the final question about cash pay for this med. Yeah, it's really not a cash pay med. The medication is quite expensive. Again, if it's NK and you can document corneal sensitivity and a decrease in that, typically you're going to be able to get it covered. If they don't have insurance, then the company has a way to really help out some of these patients, which has been really nice as well. So some great questions. All right, we're going to keep moving. So this is a patient, 19-year-old female with a painful red cloudy left eye, came in, does wear contact lenses, but of course told me she never slept in them. Do you always believe your patients with contact lenses? With what you see here in a little bit, you may or may not believe her, but I'm going to trust her. She says she doesn't sleep in her contacts, cares for them well. I've been dealing with a foreign body sensation for a few weeks that had increased with pain and discomfort. She'd seen in an emergency room a primary MD, so not an eye care provider, who had actually started her on Neopollydex. And so she'd been on that for a week or so, not improving. Her best corrected visual acuity was about 20/40. Surprisingly, it was that good because when you really look at the slit lamp examination here, she had this kind of branching ulcer with the satellite lesion. She had about 1+ cell in the anterior chamber and 2+ injection. of the conjunctiva as well. And you can see this particular lesion, which is scary to me. It's stained. This is definitely ulcerated. And I'm going to talk a little bit about culturing here in a little bit, but this really fell into my kind of 3-2-1 rule pretty easily. The lesion, no matter where it's located at, if it's 3 millimeters or bigger, I'm going to go ahead and culture these. This one was definitely bigger than that. If it's 2 lesions or more, so if I see 2 lesions, regardless of where they're located at, and 2 lesions that are ulcerated, I'm going to culture those. And then also, if I see a lesion that's within 1 millimeter of central axis or visual axis, I'm going to culture that as well, regardless of the size or regardless how many there are. So that's kind of my rule of thumb when I think about culturing these types of lesions. I think 3-2-1, again, 3 millimeters in size, no matter where it's located at, two lesions or more, and then within 1 millimeter of the central axis. And so this is a scary lesion, just the appearance of it. So what other tests should you perform? I kind of gave this away, so I'm going to go ahead and skip this particular polling question if that's okay with everyone, because you got to culture this based on the rule that we just talked about. It's really essential. And I'll go through some culturing here in a second, but what came back in this particular culture was a positive result for a nocardia. So this particular bacteria is very aggressive. And, a lot of times when you culture, you're not always going to get a result back. And so it's very important not to hesitate on treatment. We'll touch on that here in a second. About 50% of the time, you can get a positive culture result back. But unfortunately, about 50% of the time, you won't get something back. And so you're going to have to make a judgment call immediately and treat these particular patients. And we're going to get into that treatment here in a second. And so for this particular patient, I went ahead and treated with fortified antibiotics. We initially started, before we got the cultural results back, with vancomycin, tobramycin every hour during the day. And then I actually treat during the night as well, every hour, to make sure that I'm getting really good coverage within the first 24 to 48 hours. When I found out that it was nocardia, the beauty of culturing, if you get a positive culture result back, is they'll give you susceptibility results. And I'll show you a few printouts of that here in a second. And so with those susceptibility results, we were able to find out that really the ideal choice for the particular patient, and we don't have to launch this poll, was E, or amikacin, which was dosed every 1 hour. And so that is why it's so important, number one, to not pause on your treatment. I started with fortified antibiotics, but there's no problem with altering what you're doing when there's something better available. And for this particular patient, based on what the culture results showed us, amikacin was the right choice. We ultimately started treatment with that particular antibiotic every hour during the day, every hour at night. And this patient got a great result. The ulcer resolved fairly quickly. And this patient ultimately got back 20/25, 20/20 vision with a pretty significant corneal scar. And that was even with just a soft contact lens. So they didn't need a specialty contact lens either. So really, treatment is aggressive, as I mentioned, every hour during the day, should be every hour at night as well at the beginning. And then you can taper that back over time as the patient begins to improve. So let's go through kind of managing these and what we should really think about. So the location is crucial. Remember, if you see a central lesion, a lot of times that needs to be cultured, but quite often that's a virulent pathogen. When we think about central lesions, that area is kind of an area that is it's the immune privileged area of the cornea. And what does that mean? There's no lymphatics in the central part of the cornea. There's no blood vessels in the central part of the cornea. So immune privilege, we shouldn't see a bunch of inflammation. We shouldn't see infiltrates, those types of things. So if we see that, that should immediately raise a red flag that you could be dealing with, and likely are dealing with something infectious. If it's more peripheral, near the lymphatics, near the blood vessels, then I lean more towards it's probably inflammatory in nature. And I lean more towards this could be more of a staph marginal type of situation. The size of it matters. We want to compare that. Again, if it's 3 millimeters or larger, I don't care where it's located at, I'm typically going to culture that. This particular patient, you can see this peripheral lesion here. This did stain slightly, but being as close as it is to the limbus, this to me is very likely going to be inflammatory. And that's exactly what it ended up being, was an inflammatory or a staph marginal inflammatory keratitis, and not something central where I was worried about a microbial or infectious keratitis. When we look at infiltrates, examine them. Do they have perfectly round borders? Do they have fuzzy edges to them? If we see fuzzy edges, fungal should at least drift to the top of our differentials. Are there single or multiple lesions? If we start seeing multiple infiltrates, we're thinking more infectious in nature. We're thinking possibly more fungal in nature. Single lesions bring less concern to me as well. So this is kind of a breakdown when we look at sterile versus infectious, a variety of different things here. And again, this will be in your handout. And so feel free to download that. I know there's a link for that as well that you can look at that too. Couple quick questions that are kind of popping up, and I like to kind of take these. Do I ever start a loading dose? I think you can definitely start a loading dose in your office. I would do, every 15 minutes. You could do it for the first hour, and then you're already on your way. I don't typically do that. It doesn't mean it's right, but you definitely could do that. We have the advantage of having a compounding pharmacy literally a block away that can get us the medication very, very quickly. But I have no problem with going ahead and doing a loading dose. When we're looking at Nocardia, a question came up. How do you culture for Nocardia? I'll get into that here in a second. So I'll have you hang tight. I'm going to get into culturing. And then the last question here, for those who have not RX'd something before, how do you RX for fortified antibiotics? You do have to go through a pharmacy that does do fortified antibiotics because they have to be compounded. And really all I do, honestly, is I get on the phone with the pharmacist and we talk through and I RX it that way. Typically they have the experience around it. And so now at this point in time, my technicians do it. I just tell them, hey, I want fortified antibiotics. And we go through that. And I'll go through a little bit more of that here in a second. Some great questions. Stromal thickness. I touched on this a little bit. If you see excessive edema, you have to think herpetic. It has to go to the top of your list. It has to be there. A lot of times you don't have a ton of edema when you're dealing with microbial or infectious keratitis because the patient typically will be in your office fairly quickly. It hasn't penetrated as deep. With HSV or HZV, a lot of times you will see a lot more edema. If you see an aggressive or a melting type of situation, a lot of times Pseudomonas needs to go to the top of your thought process when we're talking about thinning or melting. Anterior chamber reactions. Again, remember that the hypopyon that you see in that inferior image there is not infectious. What's infectious here is the cornea. The hypopyon is the reaction to what's happening on the cornea. To my comment earlier, if you see KPs on the cornea, that suggests herpetic in nature. That really needs to go to the top of your list. It's something that you need to consider. And again, just because you see an anterior chamber reaction does not necessarily mean it's infectious. It could be viral. It could be herpetic. But you still need to think infectious as well. And then pain, a critical question. If I see a patient with an epithelial defect, maybe looks a bit infectious, but they have zero pain, that raises a red flag that, am I dealing with a neurotrophic cornea? If they're in a ton of pain with that epithelial defect and it looks infectious, I'm leaning less away from neurotrophic. I'm thinking more likely that it's probably infectious. And so you want to consider that or think about that as well. Acanthamoeba, of course, would be if there's a ton of pain. That would be something in those situations, but not all acanthamoeba patients will have a lot of pain. I want to share a quick imaging tidbit with you that really one of my colleagues, Dr. Alison Bazung, shared with me. And this is actually her images here in her slide. And where I've really found this helpful is with fungal etiologies. And that's in the red there, number 6 and number 7, the two red ones. And I used to never use anterior segment OCT on anything infectious in nature. I didn't see the need for it. I felt like on the slit lamp, I'm able to examine, I'm able to understand what's going on. But fungal keratitis can be very difficult to manage, and they can be very difficult to diagnose as well. And when you look at the literature around these cystic spaces on anterior segment OCT and the setting of an infectious keratitis, this goes hand in hand quite often with fungal etiologies. And so I've started to get some anterior segment OCTs on patients when I see a corneal ulcer that maybe looks a bit suspicious for something that's fungal. We'll get this anterior segment OCT. And if I see these cystic spaces, a fungal keratitis really jumps towards the top of my etiology. I'm still going to go ahead and culture and manage these patients. And I may not introduce a fungal agent right away, an antifungal agent, but I do think that anterior segment OCT can play a role. And I do think it's something to consider when you're dealing with something that maybe looks a little bit suspicious. Confocal imaging, of course, can be very helpful as well. These are usually only found in specialty cornea practices. We don't even have one in our practice, and we're an anterior segment practice. So we actually send out if we need this. But with new culturing techniques, it's really helped to not need this quite as often. When should we culture? Really 7 different reasons that we consider culturing. I kind of threw these up there, and then I kind of talked to you a little bit about that 3-2-1 rule. I'm going to take you through about 3 different ways that we can culture. There's a quick culture out there. The really nice thing about this is you have 1 canister, you have 1 swab, you go ahead and do the culture, and I'll show you how to do a culture here in a second. You go ahead and put it in this particular canister, it gets sent off to a lab, and then results are sent to you. I'm going to go through some PCR testing in a little bit. That's very similar to this, but a quick culture is a nice option if you're someone that doesn't do a lot of culturing, because plates can expire. It's very wasteful. If they're expiring, you're having to throw them away. It can get expensive. And so quick culture is nice because you can buy these when you need them. They last a bit longer. The expiration date is much less with these particular culturing groups. In our practice, we've shifted a little bit. We used to do all plates. We still do a fair amount of plates, but we're now doing a lot of PCR testing, which I'll show you that here in a second, or preliminary chain testing or reactive testing, so PCR testing. When you're dealing with plates, there's really about 5 different ones you're going to do. You do chocolate and blood, which is looking at gram-negative and then gram-positive and fungus. You have your Sabarud's medium, which is looking specifically at fungal growth. And then you have thioglycolate, which is your anaerobic. You use a different swab for each one of these, and I'll show you a video of that here in a second. And then I also do a rapid identification. And what you're doing here is you're getting swabs, you're putting them on these plates, it's sent off to the lab, they look under the microscope. They're not necessarily going to be able to tell you, boy, this is the bug you're dealing with. It's Pseudomonas, or it's acanthamoeba, or it's a certain it's Fusarium. But what they can tell you is you're dealing with bacteria or you're dealing with fungus, and so you can get that very rapidly. Here's how we do a culture. Good idea to give the patient a drop of Piperacane. Very important to get the lashes out of the way so you don't contaminate your culture. And then you want to get into the ulcer bed. So there's a lot of overlying tissue that can get in the way. That's necrotic. I like to kind of sweep that out of the way, get into that ulcer bed, get deep into the ulcer bed. And again, you're going to do this for every plate if you're using plates. Again, if it's a quick culture, you'll do that once. If it's PCR testing, which I'll show you here in a second, you're just going to do that once as well. And then I go ahead and I plate it. And I make 3 little C's on the plate. Stands for corneal culture. I know, really, really clever, mind-blowing to everyone. But I make those 3 little C's, and then that plate and the other plates are sent off, and I hope that I get results back. What we've started and shifted to in our practice is doing this PCR testing. And there's a company called HealthRx that provides this. And you can see all the different types of bugs down here in the left image here that it'll test for. And you can get quick turnaround with it, really within about 24 hours. It will give you the different pathogens that you're dealing with. You can see that over here on the right side, that this particular patient that we went ahead and cultured had Pseudomonas. So they had Pseudomonas. It was detected, and the microbial load was very high in this particular patient. They also had a few other different types of bacteria, a normal flora pathogen, and then actually they had some Demodex that tested out as well with microbial loads. But the concern with this patient was the Pseudomonas. And then the other thing you get with it, which is really nice, is then this personalized summary of what types of agents are going to be effective against it. What should you prescribe? What should you manage with? Again, you don't want to wait for the test results to come back. You want to go ahead and manage with the antibiotics, which we'll talk about next. But it's nice to know that you can make that switch once you get these particular results back. So the real advantage of this, which has been really nice, is it's just one of these. It's just this canister with 1 swab. You don't have to have a bunch of plates. You don't have to have a bunch of swabs. And you do it one time. You put in this particular canister, it's sent off, and you get this result with all these different things that are being looked at. So a very nice test that, we've really attached to and grown to like over the last, really we've only had it for about 2 to 3 months. So we're going to wrap up just talking about kind of infectious keratitis management and treatment. I got about 10 minutes left, and then we'll take a few questions. When we think about fluoroquinolones right now, I would tell you that second generation fluoroquinolones probably don't serve much of a purpose, except when you're dealing with something like Pseudomonas, where ciprofloxacin still shows very good efficacy against that particular bug. The fourth generation fluoroquinolones, your gadafloxacin, moxifloxacin, besofloxacin, still do show good efficacy against a variety of different microbial bugs that are out there. And so these still do serve a purpose. It's something to consider. I lean towards fortified antibiotics because the fortified antibiotics, specifically vancomycin, very effective against gram-positive, tobramycin, very effective against gram-negative. But I do realize that not all of you have instant access to those fortified antibiotics. One thing I will say that another agent that is very effective against gram-positive or MRSA types of bugs is polytrim. Very inexpensive, something that I utilize quite often in combination with my fortified antibiotics. And one other comment with besofloxacin, remember there's no oral agent to besofloxacin. So if we look at the ARMOR data, besofloxacin really has outperformed the other two fourth generation fluoroquinolones. You want to be careful though with besofloxacin because when it's on the eye and you're using it with maybe another agent, it does a great job of preventing other agents from penetrating and getting where it's supposed to go. That's just the type of drug that it is, the type of preservative that it has. Does a wonderful job of getting besofloxacin where it's supposed to go, but can block out other agents. So I'm very careful if I'm combining it with something else. Fortifieds are still probably the go-to for microbial keratitis, the bottom two, vancomycin and tobramycin being those ones, gram-positive, gram-negative. Again, the way that I'm going to treat these patients every hour during the day, every hour at night initially, they're not going to love you for that. They're going to hate you for it actually. And then you can back off once you know that it's moving in the right direction. This is a study published in Cornea in 2020, comparing a fourth generation gadafloxacin versus a fortified tobramycin cefzolan. And why I threw this study up there is it's interesting because a large study, 204 patients, these patients all had culture positive microbial keratitises. Half these patients were put on gadafloxacin, half these patients were put on tobramycin cefzolan, those fortified antibiotics. And they both actually performed very admirably. They actually worked about equally, the fourth generation versus the fortified. Now, again, I lean towards fortified whenever I can, but I throw this study in there is that there is evidence that those three fourth generation fluoroquinolones that are out there are good choices if you're in a situation where you need to aggressively treat, and that's what you have access to. The ARMOR study has helped to shed a lot of light on this. I'm not going to spend a ton of time on this. I talked about a little of this already. Point 3 being that besofloxacin looking to be a little bit more efficacious than the other fourth generation fluoroquinolones. And I think the other big take home being that vancomycin, very good against gram-positive, not a lot of resistance, thankfully, in the world that we're using it today when we talk about vancomycin and microbial keratitises. I threw this up here really quickly because at times when you're dealing with Pseudomonas is the most common, you're dealing with a situation where the cornea is thinning, you're worried about a corneal melt. What can you do in those situations? Obviously, you're going to treat the patient with an antibiotic. You're going to be very aggressive with that. You're going to consider ciprofloxacin as well because it still shows to be effective against this. But you also may want to consider using a doxycycline or a vitamin C. I wouldn't use both, but I would use one or the other. And why a vitamin C? Because it does suppress corneal neovascularization by this antioxidant effect, and it enhances collagen synthesis. So it helps to prevent a corneal melt. The way that I would dose it is 1 gram 3 times a day to prevent that melt. You also could consider using doxycycline. Why? Because it reduces inflammation. It decreases and helps with elevated levels of that inflammatory cytokines. It has this anticholinergic action where it prevents melting in a Pseudomonas situation. And for me, I would probably dose and typically would dose this, 100 milligrams twice a day, more of the anti-infective dosage, not to treat the ulcer necessarily, but more to try to prevent a melt from occurring. Steroids, kind of the final thing we'll wrap up with. Definitely still controversial when we talk about corneal ulcers, but I believe necessary. Not something I will lead with, not something that I jump in and say, boy, this is a microbial keratitis. I need to add antibiotic and steroid. But down the road, once I know that I got the ulcer turning the corner, once I know that it's getting better, I need to treat the inflammation. And what is the data on the SCUT study? Well, this was a study that looked at 500 eyes. These patients all were put on moxifloxacin every hour while awake for 48 hours. And then a group was randomized to topical corticosteroids, and the other group was randomized to not get it. And in this particular study, it was predphosphate. They were given predphosphate 4 times a day for a week, twice a day for a week, and then QD for a week. When you look at the 3-month data on this, 3 or 4, very important points that came out of it. The last 2, probably the most interesting, no statistically significant difference in vision between the steroid group and the placebo group at 3 weeks or 3 months. No statistically significant difference in scar size at 3 weeks or 3 months. And so you can look at this in a couple different ways. You look at it as, well, if I don't do a steroid at all, it appears to me that there's not a problem. The patient didn't get less scarring. The patient really didn't get visual acuity. On the flip side, we know that steroids help with inflammation. We know antibiotics don't. And if you use one, there really wasn't a statistically significant difference either. Depends on what side of the coin you're on and the way that you interpret the data. Now, when you look at the 12-month data, looking around the SCUT study, there was a trend, not necessarily statistically significant, but there was a trend for better long-term visual acuity outcomes. And so when I look at steroids, when I think about steroids, the way that I kind of use them is I usually have a patient on an antibiotic for at least a week aggressively. And I always we try to measure the size of the lesion. And if we're seeing improvement, we'll consider going to a steroid around that week mark as long as there's improvement occurring and we're moving rapidly in the right direction, because the steroid will decrease inflammation significantly. It a lot of times will help you heal the epithelium. And so I don't wait till the epithelium's completely healed. It will help with that. But you want to be careful in microbial keratitis is if you're not moving in the right direction, you don't want to just dump steroid on. And quite often I will limp in. That's the terminology I use with using steroid. I'll just dose it twice a day, morning and night. I don't care if it's, Pred. I don't care if it's, like a Durezol, whatever it may be. I'll just dose it twice a day very lightly, because a lot of times just doing it twice a day will really calm down that inflammation. I will say that as you all start to culture more, which I'm hoping after you're done with this lecture that you all will look into doing more culturing, maybe managing some of these things. Nocardia is the one bug in the SCUT study, the one microbial in the SCUT study that performed poorly when steroids were added. So in that particular patient we just saw in this case, that would be a patient I would be very, very careful with adding steroid based on, again, what the SCUT study said. The other situations you want to be really careful with steroid in would obviously be fungal keratitis, extremely controversial. I'm not a fan of using steroids with fungal keratitis. And then finally, anything acanthamoeba that you're concerned about, you want to be very, very careful with that as well. So when we think about microbial keratitis, you want to treat these patients very aggressively. Don't be shy with your antibiotics. Don't be shy about making them take it through the night. You're going to be friends with these patients quickly because they're going to be in your office often. You're going to see them every 24 to 48 hours until you start turning the corner and start seeing improvement for those situations. So I'm right at the time. I'm going to wrap up there. I had one more case, but that's okay. We got through kind of the 3 main ones I wanted to. I want to thank everyone again for your time spending it with me. I threw my email address up here as well. And so please email me if you have any questions, want any information that I provided you tonight.